please make Professor Zoe Wainer very welcome.
Look, firstly, thank you for the warm welcome and the wonderful energy in the room. I just could feel it when I was walking in. I'm really, really excited to be here and so honoured that you've invited me to speak today. There's many, many things that we could talk about, and I know Ewan, when he joins, will speak to his vision for community health. And obviously, I understand some of your work, and I'm really looking forward to learning a lot more about it. As I know many of you are aware, we are restructuring the department, and community and primary care will merge with public health, and I think that's just such an exciting opportunity. And it will be renamed Community and Public Health, so there will be a division in the department really calling out the fantastic work that you all do. And I think, as mentioned in my background, I was chair of the Board of Dental Health Services Victoria, so I have a really deep passion and understanding of the value that community health brings to healthcare more broadly. And as I said, just really excited to be here, so thank you again. So there's lots of different topics I could talk to you about today. I'm going to leave the vision for the system to you and to discuss with you, and would love to come back at another time perhaps to talk more about some of the principles of the work in value-based healthcare. I'm absolutely honoured, as I said, to be here, and in line with the theme of this conference, engaging with communities to address health equity the rural and regional way, I'm going to speak about a particular area of sex and gender differences across healthcare and the role of partnerships in that space. I too would like to acknowledge the traditional custodians of the lands on which we gather and pay my respects to elders past, present and emerging, and acknowledge the extraordinary contribution that Aboriginal people make to the health and wellbeing of this state, and particularly in my division in the Department of Health. I'm going to talk to you, as I said, about a very specific area today, which I'm pretty excited to share with you, and the Minister may also touch on the significant contribution that the government is making into women's health, but I want to explore it from a regional and an equity perspective with you. I also acknowledge contributors to this work in the department. This presentation is put together by my colleagues, but obviously speaks to an area that I'm particularly passionate about. So today I'm going to touch upon these three areas. Firstly, why do sex differences matter in healthcare? Secondly, when do we know that sex and or gender differences impact patient outcomes, and really importantly, health outcomes that matter to community and populations and people? Not the outcomes that the department measures or that we look at really the absence of negative outcomes, but really thinking about what those positive health outcomes might be. And finally, how do we change the way care is delivered to address that inequity? So why do sex differences matter? When I was an intern at a hospital in Victoria in a cardiology team, I was voluntold really, to present a New England journal to the Journal Club. That article was about the fact that women have worse outcomes in cardiac disease once it's established. It explored the fact that once a woman presents to an emergency department, it takes longer to get diagnosis, it takes longer to get to a cath lab, she will have worse outcomes as a consequence. The cardiologists furiously agreed that they didn't treat their female patients any differently, which in fact might have been one of the problems. But the professor of the unit at the moment stood up and said, look, it's a very interesting paper, but I think we can't be expected to undertake research into all minority groups. And probably not what was not one of my last career-ending moment. I did bravely put my hand up and say, Professor, I'm not sure by definition 51% of the community can be considered a minority. Of course, he backed down straight away, and I think also importantly, we do actually need to do research into priority populations and minorities, so he was wrong on two fronts there. But boy, did it expose to me the unconscious bias that's built in our system, that women are seen as a minority. So just briefly, I'm going to define sex and gender because people use these terms interchangeably and they actually mean different things. They are really quite distinct, and if we don't use the proper meaning, we actually can really get confused in causality and understanding how we solve problems and understand health outcomes. So according to the World Health Organization, sex refers to the different biological and physiological characteristics of females, males and intersex persons, such as chromosomes, hormones and reproductive organs. Gender, however, refers to the characteristics of women, men, girls and boys that are socially constructed. This includes norms, behaviours and roles associated with being a woman, man, girl or boy, as well as relationships with each other. It's a social construct. Gender varies from society to society and community to community. As we heard, each community we know is different and changes over time. So in reference to sex, we speak about females, males and intersex. In relation to gender, the terms boys, girls, men and women. I always find it curious when I hear scientists talk about the gender of a mouse, because if you actually understand those, the actual definitions, it makes me wonder, was the female mouse wearing a pink dress? Is that how you can tell their gender? We really mean sex. And I think it's really important to think about why. I can give you an example about why that matters. I did my PhD in lung cancer and the fact that, in fact, men have worse outcomes with lung cancer. And the reason that we've seen changes in behaviours in terms of both outcomes and rates of lung cancer in women is that in the 1940s, we decided as a broad society that it was socially acceptable for women to smoke. We naturally then saw an increase in the rates of lung cancer 30 to 40 years later. That's gender. We also see that men have worse outcomes and women have better outcomes. That's predominantly due to sex. So if we use those terms interchangeably, you can see we actually get quite confused. And one of my dear PhD supervisors, who was very proper, and I think the reason we use gender, not sex, is that it's worried it might be interpreted as a doing word as opposed to a descriptive word. And he kept saying to me, gender, and I'd say, no, Ben, it's sex. And anyway, one day he came up to me at conference and he's like, right, I get it, sex, sex, sex. And it's like, once is good, Ben, but that's great. Glad you're on board now. So when do sex and gender differences impact patient outcomes, and how does that impact equity? I'm just going to define women's health, and that might sound a bit simplistic, but bear with me because it will help as the presentation goes on. Of course, women's health includes much more than just sexual and reproductive health. Every cell in our body has a complement of sex chromosomes that does a whole range of things beyond sexual and reproductive health. When we consider women's health, we incorporate both female-specific conditions, whether tied to women's reproduction or some other facet of women's biology, and general health conditions that may affect women differently or disproportionately, as well as conscious or unconscious bias. And I just shared one of those unconscious biases in the 51% story. General health conditions connected to women's health are those that affect women firstly differently, such as cardiovascular disease, and I'll talk a bit more about that later on. Disproportionately, including autoimmune disease, migraines and osteoporosis. And osteoporosis is a really interesting one because, in fact, men have worse outcomes because it's seen as a women's disease. So not only is this a conversation about 51% of the population, it's actually 100% of the population, because understanding the difference between men and women is really critical in healthcare. And then we have women's health that's characterised by gender-based discrepancies in care, for example, pain management and mental health. Women's health also includes general health conditions for which sex differences are really not precisely understood or sufficiently studied, and that includes Alzheimer's disease. Scientists and medical professionals increasingly recognise that multiple diseases and conditions affect women differently than men, and that treatments and therapies can and may differ in both subtle and significant ways. Some of you may be familiar with the book called Invisible Women. Perez, the author, used the term invisible women, whereby men are seen as the norm, reference back to my 51% example, despite all the evidence of sex and gender differences. We see conscious and unconscious bias, we see medical misogyny, and the assumption that women are a minority impacting women's health outcomes. Further compounding this invisibility is incorrect use of the terminology in research, and eventually that finds its way into policies and practice. Notwithstanding this, what do we know about sex and gender differences in health outcomes, and why does it matter?
Early last year, the FDA made a surprising announcement. It cut the recommended dose of the nation's most popular sleep drug, Ambien, by half, but only for women. Lester Stahl learned how much different men and women are when it comes to medicine. Here's a preview of her report for Sunday night's 60 Minutes.
We have generated just a ton of information that suggests that there's sex differences everywhere.
Larry Cahill, a neuroscientist at the University of California, Irvine, used to share his field's assumption that males and females outside the reproductive system were fundamentally the same. But he's changed his outlook 180 degrees. Ambien, he says, is a case in point.
Ambien, prescribed 40 million times just last year. Approved 20 years ago. We're only now finding out that women have been prescribed a dose that's twice as high as they need.
That is a textbook example of what's wrong. How did it happen that for 20-some years, women, millions of them, were essentially overdosing on Ambien?
The FDA says it made the change after new driving simulation studies established what amount of Ambien or Zolpidem in the blood the next morning could be dangerous for driving. Dr. Sandra Queter, Deputy Director of the FDA's Office of New Drugs, says only then did they realize women could be taking too much, since women metabolize the drug differently than men.
So if I took Zolpidem and my brother took the same dose, probably the maximum level of drug in my blood would be 45% higher than his maximum blood level.
Now that sounds substantial.
It is substantial.
If science got Ambien so wrong, does that tell you that we really need to go back and review
Yes.
what? Everything?
Pretty much everything, yeah. Is once you see this difference, and that difference, and that difference, and that difference, and that difference, and you see this thing's everywhere, you go, wait a minute. So the assumption we're making that it really doesn't matter, sex, is not a valid assumption. It may not matter. It may matter hugely. It may flip your results on their head, and you don't know. So what happens is you start to realize, wow, the status quo is not okay. The way we're doing business has to change.
Lester Stahl is with us. Good morning.
Morning, Charlie.
So this is interesting. What surprised you most of all the things that you found out?
I guess what the big thing is how pervasive the differences between men and women are. It's not just that we metabolize medicine differently. Our lungs are different. Our cells are different. Our skin is different. We used to think it was just, you know, the gynecology areas, the bikini medicine, as they called it. But now we're learning that we are pervasively different at every level.
Why didn't we know this before?
You know, that's a great question, because research, and it still is this way, research is done originally on animals, and they use only male animals to this day. Now, they used to only have male in the human studies, but now they have females in the human studies. However, instead of seeing how women react versus how men react in the study, they put them all together and take the average.
You know, Leslie, I remember when Dr. Bernadine Healy took over the NIH, and she said, what, all our taxpayer money, we're only doing tests on males? This is in the 1990s that they first started including women.
Can you believe we haven't figured out that if you put the women in, you should be looking at them separately?
Right.
They don't.
And it even includes, in your point, aspirin. We're all told, Dr. David Agus is here very frequently and tells us to take an aspirin every night at bed. That affects men and women differently, right?
Well, what Larry Cahill just said is, we don't know.
Yeah.
And the FDA says they are not going to go back and look at all the other drugs. They're going to go back and look at other sleeping medications, but not everything else that's on the shelf right now. And you think about how much that would cost. Think about how many medications. I mean,
go ahead.
Leslie, if we metabolize Ambien differently, do we metabolize statins differently? I mean, the list could go on, because men and women are taking the same amount when it comes to Lipitor and other pills.
We don't know.
And we may be
that's why Larry Cahill says we should look, but they're not going to.
But why wouldn't they? That's the thing. Why wouldn't they go back?
Because it's too expensive. It's ridiculous how many medications are on the market. I mean, it's not just statins, it's antidepressants, it's everything.
And men may be taking too little.
Exactly. Exactly, because they take the average. So, you know, it's big. And the differences, as I say, are everywhere. They're finding our hearts, well, we know heart attacks are different. Lungs are different. Skin is different.
But can you imagine some kind of pressure developing for forcing the FDA to go ahead with more change?
Well, just try to think about, I have no idea how many medications there are in the market, but there's a medicine for every organ and every disease. It would be.
You would think also that there might be a market incentive for drug companies, though, to do this, because then they could market more, this is a drug specifically for women, and this is a drug specifically for men.
From now on, from this point forward, they will insist on separate, for the FDA will insist, for future drugs.
We'll
Thank
get
you so
people
much.
talking. Yeah.
Pleasure.
I certainly found that my PhD in, as I said, which was looking at lung cancer, and really, just because I didn't know what I was doing with the statistics at the time, I split by sex and saw profoundly different results. And if I hadn't done that, it just would have looked like a mildly prognostic test. And so for me, that was just this light bulb moment of thinking, wow, I really need to track this down. So I want to share some examples to illustrate why sex and gender differences are extremely important and particularly when we consider health outcomes and equity. And these are just a few examples, and there are many more known differences and many yet to be researched. It is well known that women are at a higher risk of developing certain medical conditions such as rheumatoid arthritis, multiple sclerosis, fibromyalgia, and Alzheimer's disease. However, reasons for this remain under-researched. A recent example of sex and gender blind healthcare is COVID-19. It's well understood that there are differences between men and women when it comes to our immune system function, with men more likely to have poor outcomes from acute infections and women more likely to have autoimmune diseases. However, COVID-19 has demonstrated that men, in line with this, are more likely to die from the virus, and some research is now showing that women are up to 3 to 4 times more likely to have long COVID. So just consider the impact on our healthcare system, where the vast majority of the broader workforce is female and greater risk due to exposure in the healthcare workforce. And for what it's worth, PPE is designed on men's anatomy. So we really have to take a good look at how this might impact our broader health workforce as well. There are instances where we know little about specific health outcomes in men, and I mentioned osteoporosis as an example, where the assumption is that it is a woman's health issue, and hence the pathology, diagnostics, and treatment in men are not as well understood. The same can be said for breast cancer, and men have much worse outcomes in breast cancer. Closer to home in Australia, we have examples of deeply, deeply baked in unconscious bias in public health funding, whereby if a clinician undertakes an ultrasound, they get more reimbursement if that's of a single testicle than a woman pregnant with twins. So it starts in research. This structural and unconscious bias in healthcare, which just creates these research gaps and consequences for both, as I said, men's and women's health outcomes. Up until recently, research was dominated by male researchers and still is in many leadership positions. And this is where the kind of unintended co-production becomes important. It takes women to see that women are missing from trials. And as I said, my own PhD was a good example of that. We know in medical research that the sex of cells, where we begin in the research pipeline, is often ignored in the lab. And I remind you, every cell has a sex. Male animals are predominantly used in animal research to remove the potential impact of the estrous cycle, but we don't then undertake the research to put the estrous cycle back in to understand what will happen when we prescribe that for women. And that includes in diagnostic and treatment research. And clinical trials often fail to disaggregate results by sex, so they don't split the populations and compare them. And in fact, almost in acknowledging that sex will impact this, what they do is put it into a multivariate analysis, sex that is, which actually removes the impact of sex from the study, and it doesn't help you understand if there's a difference between the two populations. At times, the failure to include male and female sex and compare is attributed to the additional cost of having to increase the denominator to get the statistical accurate data. Firstly, that's just poor science. And secondly, fails to take into account the full research pipeline, starting at basic research, but it ends in clinical practice. In America, there were 10 drugs withdrawn off the market over a 5-year period. 8 were because they didn't study the side effects in women, and they had serious side effects in women. So when we look at the full pipeline from research to clinical practice, we cannot afford to ignore this very important element, as it is a quality and safety issue, it's an economic and productivity issue, it's a health system, a sustainability issue, and we know we have to get the best health outcomes the first time round to reduce waste and complications. And as I said, it takes women to notice women are missing. And that's not because men don't care, of course they do. It's a psychological phenomenon called the privilege of the partial perspective, and is really the reason why diversity is so incredibly important at all levels. This is a research study that actually kind of really blew my mind, I have to say, because I thought, having done a PhD in this area, I really understood sex and gender, and this takes it to a whole new level. So they were looking at sex differences. It was a study looking at pain receptors in animals and responses, and they were getting very discordant results, and they couldn't understand it until somebody had the light bulb moment idea to look at the sex of the researcher. So the animal would display the pain if the researcher was female, but it would hide its pain if the researcher was male. So go back and think of that video where the neuroscientist was saying we have to go back and look at everything. And that takes, I think, for me anyway, really to a whole new level of how this impacts health outcomes and equity in outcomes. So cardiovascular health is another example, and I think this is where we in community health and more broadly can really collaborate, and there are already some fantastic collaborations I'm going to talk about towards the end of the presentation. As clinical knowledge of cardiovascular health is based predominantly on men, and women can have different symptoms, and I will note that they're called atypical symptoms in women, despite being 51% of the population, therefore probably typical. Clinicians are not taught what to look for. We are also socialised to minimise women's pain, and the diagnostics of ECGs and troponin are based on the male normal. And this means that the diagnosis in women can be missed, delayed, or misdiagnosed entirely. So in terms of the incidence of cardiovascular disease and hospitalisations, of course I don't need to tell you this, but this increases with levels of remoteness. Compounding on these inequities is that the incidence of cardiovascular disease hospitalisation increase with the level of rurality. The majority of Australian population lives in metropolitan areas, and we should strive to have equal health outcomes irrespective of postcode, but we know that's not the case. And more can always be done and must be done to improve health equity in regional and rural Victoria. I'm pretty sure I'm preaching to the converted at this conference on that one. At a global scale, women's heart health is impacted by a variety of factors, and they experience worse outcomes once cardiovascular disease has been established when compared to men. In a 2018 study published in the Medical Journal of Australia, a woman in Australia presenting to an emergency department with a serious heart attack is half as likely to get the care she needs and twice as likely to be dead in 6 months when compared with a man with the same condition. We take it to another level. In addition to that, women have better health outcomes if treated by a female surgeon or doctor. And this is a really interesting example, I think, of the concept of co-production in the clinician and the patient relationship. There's additional research that shows that, in fact, if your sex is matched, you have better outcomes too. And there's a variety of reasons for that. But if you're male and your clinician is male, you may have better outcomes. And equally, as I said, if your clinician is female and you're female, you are likely to have better outcomes. A few different reasons, both sex and gender related to that in terms of practice, clinical practice. But female doctors often spend more time listening, or clinicians, I should say, spend more time listening and follow clinical guidelines, and that makes a difference to the health outcomes. This is another one that blew my mind when I realised about it. So, and a really notable example of sex and gender inequity in health outcomes is in a case of hip implants. So these were twice as likely to fail in women compared to men. And despite the implant being available in a range of sizes, women are not just small men. Of course, our pelvises are designed to do entirely different things. The angles are different from the hip to the knee, and yet when I talk to device companies, they just say, but we just changed the size, or, oh, it's just about the skill of the clinician. The fragile edges of women's hip sockets bear a greater load than men's, and thus increasing the risk that the implant will wear down and release dangerous metals, and that they are twice as likely to fail. And I actually had the CEO of was IPA at the time, the Independent Hospital Pricing Authority, say to me he could see that data in costing data because women have much more complications. And it fascinates me that the device companies aren't engaged in this space yet. So how do we change the way care is delivered to get better health outcomes? Some of the examples that I have referred to today clearly demonstrate that we must consider sex and gender in healthcare at a systematic level to ensure equity. To change the way healthcare is delivered, we must consider and place what matters most to the person at the centre of their care. And some of you may be familiar with the principles of value-based healthcare, and I welcome an opportunity to talk to any of you about that as well. But at the heart of those principles is the outcomes that matter to patients, and not just the negative outcomes that matter to patients. We're really good in quality and safety of saying, well, you didn't go to ICU and you didn't get an infection, but we're not really good at saying, did you actually get the outcome you were seeking from your healthcare? We have to involve our community because their voice transforms the way we develop and design not only the treatment, but a system which is centred and co-produced with those who use and need it. Victoria is undertaking systematic healthcare reform to optimise health outcomes for the whole community, and also specifically this government has a significant focus on women's health. In Victoria, we're always striving to create a high-value delivery system that centres around health outcomes that matter most to the people and the populations we serve. We're using the principles of patient-centred value-based healthcare as the fundamental driver for reform. And I actually think community health is placed to be the biggest champion for this, because this is about place-based right care at the right place at the right time by the right clinician. The principles of value-based healthcare create that framework which aligns the patient voice, population health, value creation to deliver on our objectives in improving health outcomes. And improving women's health, our Victorian Women's Health Program has a focus on health promotion and addressing the social determinants of health, often gendered impacts. So what commitments are made and what work are we doing, and where do we look to really partner with you on how we deliver this? And I want to reiterate, and I'm sure that Professor Wallace will as well, but we see ourselves as partners with you in this system. So there are a range of initiatives to raise system-level outcomes. Funding's being provided to support the health of Victorian women and girls by improving access to services and promoting best practices management of women's health issues. This includes establishing 20 new women's health clinics, a dedicated Aboriginal-led clinic, an additional 10,800 laparoscopies, and sexual and reproductive health hubs. Funding will also deliver an inquiry into women's pain management and provide scholarships to increase availability of women's health specialists. Assistant Minister Kearney at the Commonwealth level shared a story that one of her constituents had mentioned, that she was in her 70s, I believe, and was experiencing discomfort when having sex, and her GP said, well, you should be lucky that you're having sex at all at your age. About 2 weeks later, she was diagnosed with acute appendicitis, and it's just such a good example of where we minimise women's pain. So what is the vision for Victoria? And I really welcome all of your engagement in this. It's about a recognition of existing lack of data. It's about improving the evidence base upon which our services are designed through improved data collection, disaggregation, and then actioning the findings and recommendations out of the inquiry into women's pain management and the establishment of a Women's Health Research Institute. And this is where I want to invite you to all consider how you might participate and work with us in some of this really exciting work as well. So Victoria has recognised these challenges and opted to deliver what is a large capital investment in a purpose-built comprehensive health service with end-to-end delivery of care from prevention to acute management. The new Victorian Heart Hospital is on a path to delivering care differently through integrated cardiovascular care that provides the best possible outcomes for both men and women with heart disease. In line with the theme of this conference, engaging with the communities to address health equity in rural and regional way, the Department of Health is partnering with Monash Health and Grampians Health and is beginning to map the full patient journey. In fact, I want to change that to the person's journey for cardiovascular health and disease. This will ensure that this system redesign continues to keep the patient at the centre and delivers locally tailored care in a way that matters most to the patient. And I really want to acknowledge Grampians leaning in so heavily to really provide that expertise on the rural and the regional experiences as well. I think really excitingly in this space too, when we talk about people, not patients, it allows us to talk about health and prevention. It was fantastic to hear that already mentioned several times today. It's music to my ears. Because when we're doing this work with Grampians and with Monash, we're starting with prevention and seeing the journey as hopefully not becoming a patient, but if you do become a patient, then how do we invest in getting the best health outcomes for you from that perspective as well? So look, in conclusion, I'll leave you both with that cartoon, but as well with a quote from Cecilia Payne, the largely unknown astrophysicist who discovered that stars were predominantly made from hydrogen and helium and changed history. Your reward will be the widening of the horizon as you climb, and if you achieve that reward, you will ask for no other. So I ask you to widen your horizon, although I think community health is pretty good at doing that already. Challenge yourselves and others to look at the biases, embrace co-production with community to improve the health outcomes for not just 51% of the population, but recognise that this has implications for all of us across health and wellbeing, and be a part of transforming outcomes for every person regardless of their sex or gender, and ensure you challenge your unconscious bias by engaging in intentional co-production with community and with the department. Thank you so much for the opportunity.